I'm one of the SHOs working in Northwick Park ICU. Today I am going to talk about tracheostomy, a bit of laryngectomy. Sorry for that. So mainly the things I will try to cover today is an overview about tracheostomy and laryngectomy, the indication for trachea, types of trachea, types of trachea tubes, tracheostomy, daily care, the things that we need to do on daily basis and like sometimes more than one time a day, common emergencies and how we deal with that and the algorithm to deal with that. Let's crack on. So first of all, what do you think the difference between laryngectomy and tracheostomy?
It won't be refunded. She's expecting a refund.
For what?
This is our own expense.
Yeah, this one won't be refunded. They said it before, no?
Is that someone talking or?
I can hear some background noises. If someone can mute their mic, please. Over to you, Ahmed.
Okay, so mainly the difference between tracheostomy and laryngectomy is the anatomy of the airway, because if you can see the right picture, that's tracheostomy. Tracheostomy is mainly an opening on the front part of the trachea, but the upper part of the airway is still intact. So if we have this patient with a non-cuffed tube or with a cuffed tube that we will deflate, the patient can use the upper airway sometimes to breathe. But on the other hand, this patient with laryngectomy, mainly the larynx is completely out, so he has no upper airway. That's like a typical front of neck breather. The only way to breathe is through the stoma in front of the neck. Sometimes this stoma can be just the opening, and sometimes the patient can has a trachea tube put through this stoma. Okay, so what are the indications for tracheostomy? Inputs, guys. What are the indications? Anyone? Anything? 1, 2, 3, 4,
Respiratory
5.
weaning.
Sorry?
Prolonged respiratory weaning.
I'm not sure why the voice is not clear for me, but again, please.
Prolonged respiratory weaning.
Wonderful. Yes, someone who's on prolonged ventilation, and we need to wake this patient up maybe and try some physios and get them off the ventilator. Yes, what else?
If there's any max fac surgery where you can't intubate endotracheally,
Wonderful. Yes, what else? Okay, let me help you. So we have many reasons to do tracheostomy for patients. One of them you already said, when we are having a patient with prolonged mechanical ventilation, that's one reason to do tracheostomy. When we have a patient that we are trying to wean off ventilation while having an intubation, but that's not working. Of course, the other reasons you said, any reason for upper airway obstruction, infections, foreign body edema, neoplasm, mass, anything like that. Sometimes even burn can lead to upper airway compromise that needs trachea to be done to maintain a definitive airway. Airway protection in patients with neuromuscular disease like motor neuron disease is one of the things that can be an indication for trachea. Okay, what are the types of trachea? There are many classifications for tracheostomy, but mainly I will approach that from the side of how we do trachea. And by that I mean either surgical or percutaneous tracheostomy. Percutaneous tracheostomy, we can do it on ICU or in any like high-level care setting. Surgical, it has to be in theater, it has to be through a specialist surgical team. So that are the, like, the, I would say, the pros and cons, or the advantage and disadvantage of surgical trachea. Surgical trachea, it has to be done under the good things about that, the dissection or the opening will be done under direct vision. So the surgeon will be dissecting the layers of the skin and what under that, and will have direct access, direct vision. Will certainly, almost certainly, avoiding any major vessel while doing that. It's good for difficult cases, especially patients with very huge subcutaneous fat or necks that not very helpful in doing the percutaneous approach. Pest control of the airway during the procedure. Sometimes it can offer lower complication rate because of the direct access or the direct vision of the airway while doing that. But on the other hand, we have the disadvantages. Transport, it needs a lot of resources, no, a lot of arrangement. It's a surgical procedure, an invasive one. Still, the percutaneous one, again, it's a surgical procedure, but it's a minor surgical procedure. So the risks are less, or I mean, in terms of the like the things that comes with the procedures that happening, higher risk of tracheal stenosis with the surgical trachea. On the other way, the percutaneous trachea, less resources, less arrangement. It can be done locally wherever we are, mainly ICU. The mainly the risk of bleeding is less because of the we're not like opening the skin or doing any kind of surgical incisions. So that might be one of the advantages. And one other advantage is the tire fit around the tube, because we are actually opening or manipulating the track according to the size of the tube. So I'll not get into details about how it's done. I actually don't know how it's done. I know, like, just theoretically, but it's about using dilators and then fed the tube through these dilators in front of the trachea. The disadvantage might be tissue that might not be visualized. So the track that we can do might not be into the trachea itself. That's why we need to use the bronchoscopy, and the use of bronchoscopy will come with other risks with the bronchoscopy itself. It might be an injury to the upper airway, it might be something else, but that's about it. So these are the tracheostomy tubes. There are a lot of types: cuffed, non-cuffed, fenestrated, non-fenestrated, and it's mainly how is the patient. So if you have a patient who's deeply sedated on the ventilator, completely dependent on the ventilator, we might need to consider a cuffed tube more, because this patient is at risk of aspiration. A cuffed tube will be helpful in preventing this risk of aspiration after trachea. If we have a patient who is very awake, communicative, needs his voice and needs to talk, so considering of a fenestrated one might be an option if the clinical setting or the clinical scenario is suitable for that. So it's all about that. If the patient is awake, fairly awake, I can protect the upper airway, can get rid of these secretions, has effective cough, that might be an indication to use cuffless tube. But most of the time, what we use in ICU, that what I have seen, but in like as little as I know and as little as I have seen, we usually use the cuffed one, because it can be helpful in prevention of the aspiration, especially for patients after long intubation. You have these patients with cough reflex that's not strong enough to clear all the secretions, which might fall into the airway. The anatomy of the tracheostomy tube itself, we have three parts. Mainly, after inserting the tube, we have two parts. One, the outer cannula, which is the upper one. This is what stay inside the stoma. And the inner cannula, this is what will be inside the outer cannula. And the inner cannula is one of the most important parts of the tracheostomy tube. I'll get to this later, but one of the parts that we don't usually see is the obturator, which is mainly the part that keeps the tube straight when you're trying to insert it or try to direct the tube. It makes the tube a little bit rigid and straight so it can go through the stoma we have done. Daily care. Let's go back. What do you think? What are the items of daily care that you see we need to do as doctors, as nurses for tracheostomy? 1, 2, 3, 4, 5. I'm waiting.
Check the trachea box regularly, every shift.
Sorry?
Check the trachea box, the spare tracheostomy.
Yes, exactly. Set the track. Oh, finally, I knew why I can't hear you guys. There was something wrong with the level of sound. Okay, so the trachea box. What else in the daily care? Come on, guys. I want to make sure I'm talking actually to you and not that the empty chairs you left.
The overhead
The inner tube.
Sorry?
The bedside signs, whether it's percutaneous or
Yes,
surgical trachea.
exactly. The sign, the shard, the bed head shards. That's very important. Okay, what else? Daily care in terms of how we deal with the trachea. What else can we do for the patient on daily basis?
To look for skin around the trachea site for any redness or signs of infection.
Thank you. Yes, the stoma site. We need to make sure there is no bleeding, there is no infection. What else? One last input and I will tell you.
Any obstructive sounds coming from trachea, like anything obstructive?
Thank you. Yes, exactly. We need to be monitoring the ventilation of the patient and the breathing sounds. Is there any obvious signs of blockage or secretions? Thank you. So, sorry. First of all, there are a lot of items that we need to deal with to take care of a trachea and to prevent complications or emergencies before happening. Bedhead signs, yes, one of them. Correct information, please. Yes, that's very, very important. We need to make sure that we have the sign and we have the correct relevant information to the patient. Is it surgical? Is it percutaneous? Is this patient, when was the stoma done? The trachea box, of course, to check if the patient has enough cough effort, if the patient is able to swallow or not, sputum, how is the sputum coming out of the trachea? Do we need to deal with anything? Let's go one by one. This is the trachea case or the trachea box. It must be there. Any trachea, we must have the trachea case available for any kind of emergency. And these are the common things that we might find there. We might find extra things, but a suction catheter, KY gel, tape, scissors, syringes, of course, trachea tubes, one the same size, one of a smaller size. These are the things that might be there. There might be other. You can on the website that it will be in the last slide. You might find a whole long list of everything you need. So please make sure you make yourself familiar with these things in the bedside. I'm talking to myself and to you guys. Daily care, humidification. especially in those patients we're trying to get off ventilation or trying to wean off ventilation. Humidification is very, very important, and that will help them clear secretions, will prevent any blockage, will prevent these kind of emergencies that I think many of us have seen with patients during their ICU stay. The patient is completely fine on trachea, minimal oxygen, and suddenly the patient is deteriorating and suffocating. So this is something that we need. Clearing of secretions. Our awesome nursing team is doing this all the time. We usually use the soft catheter, the small bore catheter, to do that. Clearing secretion is also one very important part of the daily care and preventing of the emergencies. One of the common emergencies of trachea, stoma care. You have said it, guys. We need to have a look at the stoma on daily basis, multiple times in the day. We need to see if there is any bleeding. If it's a new stoma, we need to see if there is any signs of infection. If the tube is well fit in the stoma or not. Sometimes the size of the tissue after this amount of dilatation and like manipulation can change after the procedure. There might be some sort of structure. These things we need to have a look at. The inner cannula care. So the inner cannula is the most important part of the trachea, because without the inner cannula, the outer cannula or the actual tube will get blocked. So regular checking for the inner cannula. Some guidelines said 4 hourly, but at least every 8 hours it has to be checked once at least. It has to be cleaned, and the inner cannula has to be changed from time to time. To be honest, I didn't find an actual guidance on how often we need to do that, because sometimes if the patient is producing a lot of secretions, we might need to do this more often than another patient. Cuff pressure. Again, cuff pressure is very important because we have a definitive airway that's ventilating the patient and helping the patient so much, but if we're inflating the cuff so much, that will intervene with the capillary circulation and might lead to problems in the trachea itself. So it's said that it can be between 15 and 20 centimeters of water, the pressure of the cuff. So that's something that I see the nurses check a lot of times during the day. So that's again one very important daily care. Okay, emergency care. Let's go back. What are the common emergencies we can see with trachea?
Displacement or dislodging.
Displacement, thank you. What else? What
Bleeding
else?
The trachea site.
Sorry?
Bleeding around the trachea site.
Exactly, bleeding around the trachea site. And these kind of things, I think, very, very commonly we can see in the first day or two. It might happen later if the patient is on treatment dose, anticoagulation, or for any reason, but commonly it can happen in the initial bed. What else?
Obstruction.
Obstruction, thank you. Why obstruction? Like how is going to be obstructed the tube? Secretions. Okay. Is there any other reason that you can get
Dislodgement.
blood? Yes, if the patient is bleeding, it can be blood. It can be the secretions you have said it. It can and the small part of tissues coming from the airway itself can block the tracheal tube. Okay, how you're going to deal with that if you have a patient on trachea and suddenly there is signs that the patient is deteriorating or the trachea is blocked? What signs you will get? Desaturating. What else?
You will notice phonation suddenly. The patient is vocalizing.
Okay, that's one thing. So there will be noises in the breathing of the patient. So we have one thing which is clinically the patient will start to deteriorate, maybe tachycardia, maybe desaturating, the respiratory rate will be high, noisy breathing. Okay, so to deal with that, first of all, we don't need to brainstorm. All we need to do is to follow this guidance. So that's the guidance of the National Safety Project. The red one is the one for laryngectomy, and the green one is the one for trachea. The only difference, like it's almost the same concept in both of them, but the only difference that we need to be mindful of that this one with laryngectomy is a patient with no access to the upper airway, no access from the upper part. So the only access is here. So when we say that we need to supplement oxygen here, but in the patient with trachea, oxygen supplementation will be here and here, because at one point you either the patient doesn't have a cough, or the patient has a cough and you will deflate it and use an oxygen mask or any way to supplement oxygen to the patient, and that might help with oxygenation. Okay, look at this. This is a patient who's having a problem with his trachea, and you want to see what's happening. Is it blocked? The patient is not properly ventilated. Imagine, like, have a mental picture about the things that you need to deal with: the site of the cuff, the tube itself, the inner tube, if there is any valve attached to the tube itself. And here we go. So the emergency trachea management, first of all, you're following the guidance, but that's not your actual rule. Your actual rule is to panic. I'm kidding. Your actual rule is to call for expert help and provide oxygen to the patient. Call help first. If you're not an airway trained expert, and even if you are, call for help, because you will need extra hands with this patient. So you call for help, look, listen, and feel. You wanna know what's happening. It's a critically ill patient, a patient who's deteriorating. So typical A to E scenario, but you're at the A now. You're checking what's happening. Yeah, it's apparently blocked, not working for any reason. You wanna check if the patient is ventilating or not. Look, listen, and feel. You can use a capnogram to tell you. You can use the water circuit and see if it's inflating and deflating or not. That's one other way to check if the patient is ventilating. If the patient is not, resuscitation team. And sometimes if you cannot get hold of the anesthetic registrar or the 118, 119, our registrars, calling the resuscitation team is one very important option, because you will get an anesthetist with this team, and that will be very helpful. If the patient is breathing, okay, we're happy. Supplement oxygen. We can supplement oxygen in both the face and the tracheostomy tube. Okay, what's next? So now I need to assess the patency of the tube. If there is any cap or valve, remove it, and then remove the inner tube and try to pass the suction catheter. You're able to do that. Okay, we're happy. Maybe it was just the inner tube blocked, and now we're able to do suction. Let's see if the patient is ventilating or not. Still, I'm listening. I'm trying to see if the patient is breathing. Look at the chest, see if enough or adequate rise of the chest. Look at your water circuit or capnogram to see if the patient is breathing. Still not breathing. Deflate the cuff. Again, look, listen, and feel. Again, look at the capnogram. Look at the water circuit. Is it working? Not working? Is the patient stable or not? It will depend. If it's working now, the patient will start to improve. like clinically from what you have seen initially. Maybe the saturation will start rising, the patient will be less agitated or distressed, the chest rise will be more adequate. But if the patient is not, at this point, the only option to do is to remove the trachea tube. Okay? Okay. We remove the trachea tube. Is the patient breathing? Yes or no? No. We still on this side, we need the patient is at risk of respiratory arrest and eventually a cardiac arrest. Call the resuscitation team. If the patient is breathing, so we had an issue with the trachea, continue ABCD assessment. But at this point, remember that you already called your expert, the airway expert, who will come and take it from there. Sometimes it will be just supplement oxygen through oral airway, maybe a bag valve mask, maybe putting an adjunct supraglottic airway, or through the stoma itself. Sometimes you might need to do intubation for the patient, whether oral intubation or intubation in the stoma. And because it's a very difficult call, calling the expert early will help you when you reach this phase. Very complicated? No, not very complicated, but let's make it simpler. In other words, what we need to do, the items we need to cover when we have an emergency with a trachea is O, Cisco. And O here is not, oh shit, that when you're panicking. O here is for oxygen. The C, that's the main thing you wanna deliver to the patient. Once any patient who's critically ill or deteriorating, you need to supply oxygen. So the first thing, supply oxygen after calling the expert. Deflate the cuff, not working. Remove the inner tube, not working. Consider the suction, not working. While doing that, in the background, you're using your CO2 monitor to see if the patient is ventilating or not, and eventually O, which is take the tube out. Okay. So, long story short, when you have a patient with trachea emergency, your rule is help and supply oxygen to the patient. And following the algorithm, in each step, what you're trying to do is to oxygenate the patient. And this is not helpful or not working, you move to the next step. And eventually, you might need to remove the whole trachea tube to do that. Any questions? Is there anybody still there?
Any questions from everyone? You can even type the question if you want.
Okay, I'll consider that no questions.
I'll ask you a question from my side.
Okay.
Ahmed. So if you have a tracheostomy, does the duration of tracheostomy matters, especially if you have an airway emergency or if you want to change the tracheostomy tube?
Yeah, of course, because like again, as little as I know, when the trachea is new, there is a high risk of losing the airway because the track that the trachea will fit in is not well built yet. With not like no the what's the call of this tissue, but the tissue is not well formed enough to keep the track patent. So I think in the first week there is a higher risk of this. If I remember correctly.
I'll just modify it. It's if you have to wait for first 2 weeks for the track to become patent.
Oh, okay.
And after 2 weeks, let us say even if you have a tracheostomy emergency or laryngectomy related emergencies, then in those cases it is easy to manage this patient as compared to the patient having a very fresh tracheostomy tract. Because the granulation tissue can get easily
The
dislodged.
granulation tissue, yes, that's the word. Okay.
Okay, by the
Okay.
way, for everyone, Ahmed, even for you, I have sent a link on the chat box. You can click on that link. You will get a article from the BJ. It is a recent article, and this article also mentions like whatever you have just spoken right now. It was a very good presentation, and this article has summarized quite a number of salient features. So, Ahmed, there's a question for you.
Okay.
Is pneumothorax a complication of tracheostomy or no?
Um, it's like it said that when I was reading for this teaching, it said that it's one of the complications, and when we do percutaneous trachea, the risk is less. But to be honest, I haven't gone deep on understanding how that like the pneumothorax can happen with trachea insertion. If anyone has like the pathophysiology or the pathology, how it can happen, I'm happy to.
Maybe I can give some little highlight on this. So
Yeah,
if you have
please.
very difficult landmarks in case of a tracheostomy tube, let us say goiter or a very thick neck girth. Okay, so during the time of surgical dissection, very often the surgeons might even go laterally around the tracheostomy to free the space so as to make a good hole or a good puncture in the trachea. But at the same time, when they are going more laterally, the chances of hitting the pleura or the apical dome is quite high. So that is why pneumothorax is still a possible complication. Simultaneously, subcutaneous emphysema is equally dangerous because not only it is going to affect the airway, it will affect the breathing, but it will also make your airway intervention from top also difficult. This is my personal experience also because once we had a tracheostomy patient which got obstructed, and when we tried to bag him with water circuit, suddenly his whole face puffed up and he started desaturating. But we were lucky enough to put the endo tube from top in first attempt.
Okay, that's actually interesting because yeah, sorry, I didn't thought about the part of the emphysema, the surgical emphysema. Yeah, that's actually something reasonable. Yeah.
And subcutaneous emphysema is also possible. Let us say if you have an airway emergency, a blocked tracheostomy tube or a dislodged tube, a tracheostomy tube to be precise, that tube will be present somewhere in the tract, but not anywhere close to trachea. So when you apply very high pressures, this high airway pressure is actually going to dissect around the surgical
Yeah.
site,
To,
and it
to the
will.
subcutaneous tissue.
So at the same time, you have to be very careful when you're going to use AMBU or a water circuit. Check the patency of the tube. So Ahmed, very well presented, very nice presentation and good learning points that we got today. Okay. Next, I think before I hand over to Uma, I am going to share my screen for feedback. Okay. So this is the QR code for feedback. Is everyone able to see it?
Yes, we can see it.
Okay. So shall I assume that everyone has done the feedback completed or no? Oh, sorry. I'll just put it one more time. Sorry, I am not able to open the QR code. So I think I'll hand over to Uma. Uma, are you there?
Yeah, I'm here.
Okay.
Thank you.
So I'll
I'm,
hand over to you and you can start your presentation on
Yeah.
COPD management.
I'm just trying to give me a moment. No, I don't.
Uma, are you having difficulty in sharing? Oh, okay.
Are you having the screen?
You can see your screen now, Uma. So
But
I think.
I cannot see. That's why. Just
Okay.
give me a moment.
Yeah, sure.
Can you see my presentation now?
Can. It is better.
It is better? Yeah. Thank
Yeah.
you. And good evening, everyone. This is Dr. Uma, one of the trusted peers. My topic today is mechanical ventilation, management of COPD and asthma. Good presentation. First of all, good presentation, Ahmed. It was really nice and colorful. My slides are not very great, so it is more of a talk actually. So the basics of COPD and asthma first. COPD is previously an irreversible and now poorly reversible airflow limitation, which is usually progressive and associated with an inflammatory response in the lungs. It was chronic bronchitis and emphysema before, and nowadays the difference between these two conditions are almost a blur. Uh, Typically, think of a chronic smoker. The other kind of patients are those with work exposure to pollutants, uh, those with living in heavy outdoor pollution conditions, and those with alpha 1 antitrypsin deficiency. So antitrypsins are proteases. So there is a balance between proteases and uh, this is lost in case of alpha 1 antitrypsin deficiency at an early point in life, and smoking and other pollutants are other important causes of reduction in alpha 1 antitrypsin. So basically, this results in inflammatory changes that causes the neutrophils, macrophages, and lymphocytes to release tumor necrosis factor alpha, the multiple interleukins, elastases, and proteases. These induce structural changes and break down the connective tissue in lung parenchyma. So the previous chronic bronchitis is a bronchial wall inflammation, hypertrophy and hyperplasia of the mucus secreting glands, causing copious mucosal edema. Copious mucosal secretions and edema that causes airway narrowing and airflow limitation. With time, squamous metaplasia of the respiratory epithelium occurs, and squamous metaplasia leads to further destructive changes. These are the historic blue bloaters. Emphysema is a different condition other than bronchitis. Basically, that's how we were taught. It is the dilatation and destruction of lung tissue distal to the terminal bronchioles. There is loss of elastic recoil because of the lung tissue damage, and there is expiratory airflow limitation and air trapping, which is the same pathology. These are the historic pink puffers. Asthma is typical airway hyperresponsiveness. There is bronchial inflammation for sure, but then differentiates a COPD patient from an asthmatic patient. So with an reversible airflow limitation compared to COPD patients who are almost never reversible to normal. There is airway remodeling and mucus impaction in case of chronic uncontrolled asthmatics, which makes it irreversible in further stages. So the etiology for asthma is atopy and various stimuli, which produces a specific increased airway response and some genetic and environmental factors. In everything, the pathogenesis is smooth muscle contraction, inflammation of the airway walls, and secretions in the airway lumen. So the difference between COPD and asthma, for us, we do see a very high number of COPD patients than asthma patients. Association with smoking is mostly present in COPD, not necessarily in asthma. Younger onset is common in asthma. It is much more rare in COPD, except in case of alpha-1 antitrypsin deficiency. Atopic features are present in asthma, never in COPD. The breathlessness is persistent and progressive in COPD. Think of a chronic smoker with pack years greater than 55. That's a cutoff which we uh, think of when we think about a patient coming in for a general anesthetic. So more than 55 pack years, they are high risk patients. They have obvious baseline breathlessness and they have progressive shortness of breath as they exit. This kind of breathlessness is not persistent and it's very variable in asthma. A positive response to bronchodilators is not necessarily present in COPD, but asthmatics usually respond at least minimally. At any point, there is some response to bronchodilators in an asthmatic. Steroids show a variable response in COPD. We all know that steroids have a very good role in the asthma treatment pathway. They are like the ultimate drugs we go for. The cellular infiltrates are macrophages and neutrophils in COPD, and asthma is atopic, so they are eosinophils. So, the most important pathogenesis we need to know when we are considering ventilating a patient with COPD or asthma is the end expiratory collapse, which is the most important reason why we are thinking about the mechanical ventilation of these patients as a specific entity. So basically, there is incomplete expiration. So this is an expiration problem. This is not an inspiratory problem. There is a high end expiratory volume, always residual inside the lungs. Because of that, there is hyperinflation and what we call as autopeep, intrinsic peep, or dynamic hyperinflation, which is we are very concerned about. The physiologic changes that occur when there is expiratory airflow limitation, when the patient is otherwise normal. This happens even when the patient is at home. It is compensated by inspiration by increasing the inspiratory flow and lung volume. And added to the high inspiratory drive because of the high PaCO2, the patient always has a baseline inspiratory muscle fatigue. So why we should know that this occurs in this patient is for two reasons. One, when this patient is coming in for some other procedure, so we are trying to sedate him for a small procedure, or we are considering a general anesthetic for another procedure, or this patient is coming in, we need to think of their baseline to be much worse than what we really would think. We are not achieving for 100% normalcy in these patients because this is how they have always been. A chronic COPD patient has always been having a level of inspiratory muscle fatigue, which is a most important factor we have to have in concern while trying to treat these patients. So airflow obstruction with low elastic recoil because of the lung pathology, an increased ventilatory demand because of the increased PaCO2 and a decreased expiratory time. These leads to air trapping. Air trapping finally leads to dynamic hyperinflation, which, as expected, increases the intrathoracic pressure, which increases the work of breathing. When you get into the ventilator, they are going to go in for a ventilatory dependency, and we are going to have a weaning failure if we do not understand how dynamic hyperinflation occurs and how it can be counteracted by means of ventilation. So the aims of intervention in this patient should be to improve the gas exchange and to rest the respiratory muscles. There are medical means which can be tried initially, which works most of the time, and when they do not work, we go in for mechanical ventilation. So going for ventilation in these patients has two things. I mean, the reason for that is two things. One is trying to rest the muscle, and another one is that these patients, whether they have a diagnosis or not, they have a component of an obstructive sleep apnea. So when similar to obstructive sleep apnea, these patients are going to benefit by having some amount of CPAP. So like how OSA patients respond to home CPAP, the COPD patients who are now not as stable as they were, they are going to respond to some amount of CPAP, which is going to be beneficial. And a lot of times that would be what they all needed to come out of this acute phase. NIV is always the first line. If we get a patient who is stable enough to be used, if it is possible to use an NIV on a patient, then that must be the first choice. It prevents invasive ventilation and its complications like the occurrence of a VAP, the tracheostomy and laryngectomy complications. So EPAP basically offsets the intrinsic PEEP or auto PEEP, and IPAP augments the patient's VT. So when to use EPAP, when to use IPAP, and how much, it all depends upon how much auto PEEP is present and how much VT, the tidal volume, this patient is able to produce. So there is no set parameters, there is no set modes or no set parameters on how you ventilate a patient with COPD. It is just based on an as and when basis. When you look at how the patient is, you change these settings. So if you remember, EPAP is for intrinsic PEEP and IPAP is for increasing the tidal volume. You will be able to adjust the every time you see the patient, you will be able to make changes. The indications for invasive. Hello, are you able to hear me?
Uma, yes, we can hear you.
Okay, thank you. It's been very quiet for some time, and my screen is like just my PowerPoint screen and not on this Teams screen. So I had a doubt. Sorry. So the indications for invasive ventilation is any one of these major indications, like the patient going in for respiratory arrest, loss of consciousness, agitation, which requires sedation. Sedation is definitely not a bad thing in a COPD patient. Reasonable amount of controlled sedation does achieves synchrony in the patient, triggering breaths and timing it along with the ventilator. But then when it goes beyond a certain stage, sedation might go in for ventilation. In case of hemodynamic stability, when you have a systolic blood pressure less than 70 or more than 180, when you have a low heart rate and there is reduced alertness or the patient is obviously gasping for air, you cannot try NIV. That is an indication to go for intubation and ventilation straight away. Any two of the minors where the respiratory rate is greater than 35, that is another arbitrary value. A lot of times we leave the patients to go for a respiratory rate of up to 45, 50, and patients do come around. A worsening acidosis or a pH less than 7.25. Again, 7.25 is an arbitrary value when the patient is well otherwise. We have seen them doing very well with the pH of 7.2 because basically they have always been hypercapnic. PaO2 of less than 5.3 or a PF ratio less than 200, when you are giving him as much oxygen as possible, still the PF ratio is less than 200. And a decreasing level of consciousness. All these are the minor indications for invasive ventilation. So the basics of ventilation are When we remember about the pathogenesis of these patients, so how we are going to ventilate, we are going to be as physiological as possible to the patient's baseline status. So increase the peak inspiratory flow rates, decrease the IE ratio, thereby increasing the expiratory time. More time for exhalation, more of the air that's locked in comes out. So modes. Again, we use PRV, PRVC, inverse ratio ventilation. There are a lot of new things coming with all the new ventilators. Again, the individual parameters are much more important than what settings the patient really are. An advanced ventilator definitely helps, but more in terms of the ventilatory graphics and what we learn from them and how we manipulate and how we identify that the patient is going in for complications at an early stage. So having an advanced ventilation or ventilator with the better graphics is much more useful in identifying in what way we are going, whether we are progressing or whether we are deteriorating. That is more important than going in for an advanced mode. So for an obtender or a paralyzed patient, like a patient in general anesthesia, we can still use an ACMV mode, a very old mode, which probably not a lot of people know now, or the routine synchronized intermittent mandatory ventilation. For a patient who is having some respiratory drive, better to go in for a pressure support ventilation or an SIMV. Aim to increase expiratory time in any mode. So another thing is the temptation to increase the respiratory rate and VT to normalize the blood gases. So you have a very high PaCO2, you are keen to reduce it, you keep increasing the additional air trapping, respiratory dysynchrony, increased intrathoracic pressure, and leads on to right heart failure. So targeting a normal PaCO2 also leads to alkalemia because these patients have been having a baseline metabolic compensation, which, unlike respiratory, takes at least 2 to 3 days of treatment. So, in order to renally excrete the bicarbonate, which has been building up, it takes at least 2 to 3 days, a minimum of 48 hours before we can see a response. So the best thing to do is to titrate it to the pH and not look at the PaCO2. High or low, these patients are going to, as long as the kidneys are normal, these patients are going to really do well with the whatever range of PaCO2 they are on. So better to titrate to the pH and try to keep it above 7.25. The minute ventilation should be titrated to pH is like the basic thing in COPD or asthma management when the patient is on mechanical ventilation. Again, to PEEP or not to PEEP. Theoretically, when you think that the patient is having a residual end expiratory volume that keeps building up, and we have an imagination in our mind that it is like a huge residual volume that's going to increase intrathoracic pressure, the BP falls, and all that. There is a theoretical explanation that our PEEP always tries to keep small airways open in late expiration. Think of a patient who has normal lungs and why we give PEEP for them. So PEEP does keep small airways open. The idea is to keep the extrinsic PEEP at 75 to 85% of the auto PEEP, at which stage no significant complications occur. So determining how much auto PEEP is present is a complex procedure. It requires an esophageal balloon and assessment of the abdominal muscle. So it is not commonly done everywhere, and it is not practical to always be looking at exactly how much of auto PEEP is present and trying to keep an extrinsic PEEP at 75% of this. A simpler way is to have an idea about the patient's graphs. So on a flow time graph, when the baseline never reaches zero after an expiration, that means there is some air trapping. And we can have a quantification of that in terms of numbers and identify whether it is going up or coming down. Also, in a flow volume loop, the expiratory curve never touches zero. That's another indication that there is air trapping. We can again quantify it based on this. So, a proper ventilator graphic is useful in this and not. For example, we could be really trained in a specific ventilatory mode, but we cannot expect everyone to be in that. So, uh, going for a basic mode and making sure that these parameters are properly set, that goes a long way in bringing these patients out of the ventilator. So how do you clinically diagnose that there is autopy? When a manual bag is filled in an anesthetic ventilator, there is very slow filling of the manual bag. The capno is sloping and not plateauing. An expiratory flow not reaching zero in the graph, and making proper measurements of intrinsic PEEP, which again requires an esophageal balloon dilator. In case of spontaneously ventilating patient, to find out if there is autopy, set the ventilator sensitivity at -1 or on flow trigger. Observe the respiratory efforts of these patients and see whether these efforts are getting converted into breaths. So, if the patient's efforts, which we are able to physically see, are not converted into measured breaths, that means that the patient has some dynamic hyperinflation or autopy, because the pressure gradient required to inhale is so much in these patients that the efforts, even though obvious when we look at the patients, might not be sufficient to trigger a breath. Also looking for accessory muscle use, neck retractions, and increased ventilatory drive. This gives us an idea that the patient has an autopy. So to manage autopy, have an IE ratio at 1:3 to 1:5. Allow more time for exhalation and reduce breath taking. If the minute ventilation is low with this, then this will lead to hypercapnia, hypoxia, and acidosis, worsening the patient's condition further. In such case, if the change in IE ratio is not helping by itself and is making the acidosis more, increase the inspiratory flow rates and peak pressures. But think of barotrauma when you are doing that. So the first step is to change the IE ratio. The next step is to increase the inspiratory flow rate, and further beyond go for an increase in pressures. But there's always a risk of barotrauma if we are not able to manage with just the IE ratio alone. So thinking of the other factors that affect the respiratory work of breathing, uh, make a note of these things, and if any of this is removable, we can do that. That helps in the patient coming out of this ventilatory support. So a resistive load is a bronchospasm that can be easily treated with medical management. Parenchymal compliance may be affected because of pneumonia or pulmonary edema. Again, treatable complications. The chest wall complications like obesity, pleural effusion, and abdominal distension can be managed by means of positioning. Positioning plays an important part, making the patient sit upright. We all know the significance of giving a upper body elevation. That really helps. Case of respiratory muscle inhibitors, see whether the sedation level is appropriate or it is too much. And are there any other reasons causing muscle weakness? Think of magnesium, think of potassium, think of calcium. And is there any, if in case of a critical illness, a patient who has been sick for a long time, are there any chronic atrophy possible in these patients? So in case of ventilatory circuit factors, is the endotracheal tube too narrow? Is there too high an external PEEP, or the trigger threshold of the ventilator is too low that the patient is not able to overcome and produce a breath? So the first step in treating a COPD patient who is going in for supportive ventilation is to remember the complex baseline pulmonary mechanics in these patients. They have a high ventilatory dive. They have respiratory muscle compromise. Find factors that has accentuated that and try to remove them. When there is hypoxemia, do not rush to give in oxygen. Go for the basics. Think of shunt, think of VQ mismatch, and think of diffusion defects. So hypercapnia is a different entity. Hypoxemia is a different entity. Oxygen doesn't treat all hypoxemia. Get to the basics, find out what is the reason for hypoxemia in this particular patient, and treat that alone. So, in a stable patient, even before the occurrence of an acute exacerbation, teaching patients about active expirations, slow and deep breathing exercises, pursed lip breathing, relaxation therapy, specific body positioning, and inspiratory muscle training are much more beneficial when they have an episode of sickness. And the patients already knowing this is much more useful for us. This might prevent the patient from going in for an NIV support or from an NIV support to a ventilator support. So, weaning. As our plan for weaning in any patient, plan for weaning as soon as you start the intubation decision. Address the precipitating cause. Attention to details like the ET tube size, secretions, kinking, use of unnecessary elbow-shaped parts, whether this HME is necessary, whether the HME is full of blockage, it has been changed and all that. So the regular method of weaning is to have a pressure support mode alternating with spontaneous breathing trials. And if that fails, we can go for a sequential weaning because these patients are always used to NIV. Extubate directly to NIV in case of a failed DSPT. That's another method which is probably used only in COPD and not anywhere else, but it does have been tried a lot of times and it has a good success rate. So with so many complications, do we really need to think about ventilation or should we give up? No, ventilation improves gas exchange, it gives rest to fatigued expiratory muscles, and there is relief of respiratory distress. It buys us time to treat the primary cause. The thing is to remember what led to this place and how to come out of this place. And it is not that when we intubate a COPD patient who is very sick and air trapping a lot is not going to improve at all. It is a life-saving procedure. We just need to know what is the right thing to do. So the key to successful outcome is understanding the pathophysiology, mechanics, pattern of the flow obstruction, and that there is going to be dynamic hyperinflation. So start the treatment of the inciting cause, mostly infections. Start the treatment of that cause much early. Right use of ventilatory graphics for early diagnosis and management, and get an optimal time and mode of weaning. So not waiting too long, not making it hastily. All these are very important to have a successful outcome. Thank you.
Thank you, Uma. That was an excellent presentation. And before I put the QR code again, does anyone have any doubts? Any questions?
I have one question, Uma.
Yeah.
So sometimes in the patients that usually present with acute exacerbation of asthma in the A&E, mostly we have seen them, and then they're in this acute exacerbation. So if we go for intubation in these people and we start them on invasive ventilation, there's like almost like a, I don't know, high chance of seeing them crashing and they're going into cardiac arrest.
Yeah.
Can you sort of comment on that?
Yes. So these patients are very, very acidotic and they have been hyperventilating for a long time. So the key is to keep I mean, their hypoxia is at the edge. The key while trying to induce these patients and put in a tube, if the patient is so obtunded that you can put in a tube without trying to induce and without making them stop their respiratory efforts, their high respiratory drive, without abolishing it, that will be very nice. If that is not possible, when you set the ventilator, what I usually do is I set the ventilator at a very high rate, almost 28 to 30, because they would be breathing at a rate of at least 35 to 40 minimum when we are trying to intubate them. So match that, because if we are going to give them a 500 ml tidal volume at a rate of 14 or 15 breaths, like how we do in normal patients, these patients are gonna crash within minutes of intubating. So the key to this is to really do the intubation very fast, switch them over to a type of ventilation which they have been doing. So physiologically, they have been sick for some time and still they have been trying to maintain their saturation and the pH. So simulate that as soon as possible on the ventilator. I hope it's understandable. I mean, did you get it or should I rephrase it or something?
Yeah, it makes a lot of sense. Thank you for
Yeah,
clearing that up.
and the induction agents, these patients are really sick with a lot of their peripheral vasoconstriction is because of this how they are just trying to keep themselves alive. So any small amount of, even if it's going to be 50 mics of fentanyl, that is really going to relax them and they're going to vasodilate all over. So have your vasoconstrictor drugs ready started before you try to induce them. And as soon as you put them on a tube, connect them to a mode which is like as physiological as possible, a very high respiratory rate, so that the baseline status is maintained.
Beautiful. Uma, I do have another question, if you don't mind.
Please.
So, in terms of starting NIV in the patient's COPD asthma, is there like sort of any recommendation which mode is better for which of these CPAP versus BiPAP, or is there an inclination to a particular mode?
So, as far as the lung is concerned, there are a very few places where we have the BTS guidelines for what patient can be taken up for a pneumonectomy or a lobectomy. We have how much FEV1 should be there, above that, below that. But for for COPD, for asthma, the cutoff between these things is like really arbitrary. It depends upon every single patient. So that's what I mentioned. You look at what is causing this particular, today's exacerbation, what is the reason and how is the dynamics today. So have a look at the blood gas, have a look at the patient's how much of autopeep they are developing, how much is their blood pressure, and based on that you go to a setting. So if tidal volume is very low in this patients, IPAP helps. If autopeep is very high in this patients, going for a high EPAP helps. That's how you set EPAP and IPAP. So if you are not bothered about the tidal volume and the patient's minute ventilation is so high, do not bother about IPAP, just go for EPAP. Make sense?
Okay, thank you. Yeah, thank you. Makes a lot of sense. Excellent, beautiful presentation, Uma.
Thank you, Tuba.
Thanks a lot, Uma. And I have put the QR code for feedback for Uma. If you can fill it now, that would be helpful. Uma, can you hear me?
Yeah.
Yeah. So it was a very good presentation, like a lot of learning points, both from you as well as Ahmed. We got a lot of learning points today. We also came to know like what are the indications for invasive ventilation versus NIV in case of COPD, how to differentiate asthma and COPD, and what are the things once you have used a particular ventilatory setting, what are the things we should take care of? What are the things we should be aware of? Like even other systemic issues that we should manage, like for example, cardiovascular collapse, or even for that matter, cause of the invasive ventilation, like sepsis, etc. So overall, it was a very, very good presentation, and let's. I think I'll put the feedback and let them finish the feedback. That's the only thing I can say now.